similar to the topic yesterday. So this one will be more or less a rehearsal of what we have discussed already in the parallel group, in the smaller group yesterday. This is my slide of conflicts of interest, which you need to know. So which solutions do we have available pre-hospital and at the emergency rooms or the OR to manage our patients, our trauma patients? This is the long list, and we will discuss all of them. When you go down in that list, there it says no fluids. My message is avoid under-resuscitation. Patient safety issues are there, and below that therapeutic window, which is related to the dose of the fluid, there is the risk for death or inadequate volume therapy. So no fluid, just because we are afraid of using something, is not a solution to the problem and is not a solution for our patients. My next message is avoid allergenic fluids. Of course, if you give blood, then you have some liquid substances that you transfuse to your patients. And in many countries, a one-to-one-to-one protocol has been implemented. And by adding 1 bag of each of these 3 products, red blood cells, platelet concentrates, and FFP, you end up with about 600 ml, which is quite an amount of fluid, if you will. So massive transfusion protocols have been invented in many countries, and they have been shown to decrease mortality from about 50 to 19%, so this appears to be relevant. But the question was, is it the speed of therapeutic administration of compounds, or is it really the ratio of various allergenic blood products? And according to follow-up investigations, which looked into the ratios, but also the time of delivery, one can see that before and after implementation of such a massive transfusion protocol, the ratios were similar, 1 to 1.8. But the speed of therapeutic administration was faster, so time determines trauma patients' survival. And this is statistically significant that these products could be delivered faster with such a massive transfusion protocol. Plasma has its indication, for example, for the correction of deficiencies in coagulation factor 5. This may occur late in the setting of hemorrhagic shock, of massive bleeding. So it is not surprising, and it is actually quite wise that in the British guidelines for the use of FFP, it is recommended in situations of prolonged massive transfusion, massive bleeding with a multi-factor deficiency, because it is likely that these critical factors, such as factor 5, become low and must be supplemented, and we do not have factor concentrates for that. In the Austrian TIC guideline, which says trauma-induced coagulopathy guidelines, our recommendations on the use of FFP are in that way that when you have no concentrates, then give FFP, but not a little bit, but enough in order that is able to correct coagulopathic bleeding. And this seems to be around 30 ml per kilogram FFP, so a rather big volume challenge for your patients. We could not find any consensus on a fixed ratio situation. In the ESA guideline I mentioned yesterday already, we touched down, of course, also on the use and the indication of FFP. And we suggest that FFP may be used if no other fibrinogen source is available. And the #1 treatment strategy here in this field of elective surgery is fibrinogen concentrate. 2C grading for FFP. There is no recommendation to use FFP as a plasma volume expander or as a fluid. That is important. Why is it such a low grade recommendation in the ESA guideline? Because the efficacy of plasma is poor. And when looking into a systematic review on the efficacy data available, one can see that 2/3 of patients did not benefit or even had a decrement after being transfused with plasma, while only 1/3 had a benefit in various areas of outcomes. But our awareness for the poor efficacy of plasma is not really good, so we can improve there. The risks of plasma, the list of the risks of plasma is long, and I just listed here to get a nice shape. It's not according to the fatalities or the incidences, prevalences, but still one can acknowledge that the awareness for the risks of allergenic blood products is not there and should be increased. Not only plasma has risks, but also red blood cells and platelets. And over in the literature, consistent among all the studies, you can more or less find that there is a risk. And the risk, particularly in this study, shows a dose dependency. The more you give, the worse for the patient on short term, but also on the long run. If you do not follow a one-to-one protocol in trauma patients, but rather a monitoring point-of-care-based, concentrate-based concept, then you do a more pathophysiological-oriented strategy. While administering factor concentrates, you add only about, per each intervention, 50 milliliters to the body of the patient. So in massive or severe bleeding, we need something else to achieve normal volemia in that severely bleeding patients. Not only in bleeding management, but also in fluid management and infusion therapy, we should act pathophysiology oriented. And as always, we should act fast. This is something we anesthesiologists are used to do. Also yesterday I reminded you on that nice pathophysiological concept of Matthias Jakob. And when looking now into these concepts and considerations, one can say in hemorrhagic shock, of course, the intravascular compartment is going down, the filling of the intravascular compartment is decreasing, and finally, tissue perfusion is diminished. Our strategy goals are, of course, number one, to stop further bleeding. So the surgeons, but also as anesthesiologists, together with the pathologists, hematologists, and so forth, need to do all we can to stop bleeding immediately. Time is life. But simultaneously, in parallel, we have to refill the intravascular compartment and maintain and optimize tissue perfusion. Iso-oncotic colloids mainly stay in the intravascular compartment. This is our target compartment, and as long as the endothelial barrier function is intact and not disrupted by overloading, it will stay there. While isotonic crystalloids go out of the intravascular compartment into the interstitial space. Many abstracts here on this wonderful symposium have shown that. So the direct measurement of the potency, the volume efficacy of various crystalloids, but also colloids, have been investigated by the group of Matthias Jakob. And finally, from the investigation starting in the year 2000 up to recently, 2012, there is a proof of concept that iso-oncotic colloids act intravascularly, while Ringer's lactate, as an example for a crystalloid, has a volume efficacy of only below 20%. And we learned also yesterday that there is a context sensitivity of this efficacy, volume efficacy. In hemorrhagic shock, when the filling status is down, there we can achieve the highest volume efficacy according to that context sensitivity concept. My next message is, don't give too much. Don't be too liberal to convert to a cosmetic problem or a problem with a disrupture and dysfunction of your endothelium, or your patient's endothelium, better to say. Keep the glycocalyx happy. Don't over-infuse and hyperhydrate the patients. In that ESA guideline I mentioned now in all my 3 talks on the management of severe perioperative bleeding, where we've focused on the perioperative population, not on the trauma population, but still extrapolations can be done. The statements, recommendations, suggestions can be found on that web app for smartphones at esa.perioperativeBleeding.org. Our recommendation with a grade 1B is to avoid hypervolemia. Both crystalloids and colloids can result when given too much in hypervolemia. My next message is monitor your patient. Preload optimization is recommended in the ESA guideline with a 1B grade recommendation. We recommend aggressive and timely stabilization of, for example, cardiac preload. And our chapter or parts on tissue perfusion tell you, well, we would like to have more insight into the microvasculature, but currently we can only live with metabolic surrogate parameters such as lactate clearance. In that paper, we described a pathway how we could achieve management to avoid or to correct hypovolemia. Please consider that it is not hypotension. There is a major difference between hypotension and hypovolemia. In this flow chart, you can find ideas how to proceed and how to further probably improve monitoring, hemodynamic perfusion monitoring of your patients. My next consideration is monitor potential side effects. All the drugs we give have side effects. And one of the side effects of colloids is that they may affect coagulation status. In trauma-induced coagulopathy, TIC, we have specific changes irrespective of dilutional coagulopathy, but altogether needs to be monitored. And I would like to inform you that at our society's website, www.ögari.at, soon we will launch an application for smartphones where you can see management, somehow simulate management situations in TIC situations. So now coming to the core part. Trauma, what is my personal choice of fluids, and what do I recommend my colleagues for whom I feel responsible as a chairperson? Isotonic saline? Definitely not. It's not on our list. We use it for administering drugs, for example, antibiotics and so forth, but we don't use it as a crystalloid basis. Why? We had wonderful lectures yesterday on hypochloremic metabolic acidosis and so forth. So I would say it is time to say goodbye to isotonic saline worldwide. Hypertonic saline? Well, in individualized cases, yes. We will have a lecture later on a traumatic brain injury. These are situations, for example, where we can think of it, although the studies behind have been partially stopped because of safety problems. Buffered crystalloid is the routine fluid number one. So this is our number one strategy. Hypooncotic colloids, nowadays, in that situation we have discussed now during this symposium over and over again, although it is a little bit irrational, this is now our routine fluid number two. Gelatins are our routine, became our routine in our desperate situation. We consider very carefully the contraindications, which are, for example, again, traumatic brain injury, or which are, for example, anaphylactic reactions in the past. Hyperoncotic colloids, dextrains are not available in Austria and are not a good situation in severely bleeding trauma patients. Why? Because dextrains are more or less anticoagulant drugs. So tetrastarch and 20% human albumin are administered in an individualized manner again, in that way that, for example, in patients with allergies to gelatins, then tetrastarch is our choice. 20% albumin. Albumin is rather expensive in Austria. We're very much aware of that. And sometimes we also want to dilute it, not to be too hyperoncotic, and we dilute it then more or less in a co-administered way with buffered crystalloid, because the 5% albumin is coming in Austria in a saline-based solution. Allergenic blood products, restrictive. This has really an impact on morbidity and mortality of our patients. We definitely need, and this can summarize this whole slide here, we need more studies, especially in the critically to treat population of trauma patients. Consider your safety. We have heard over and over again that the EMA has published a conclusion which says that in specific populations such as burn trauma patients, we should not use tetrastarch anymore. The availability in restricted patient populations, however, has been stated in this recent publication. Still, contraindications need to be considered and medical legal aspects are there. Don't use it according to that recent publication in burn trauma patients, in patients with head injuries, intracranial bleeding, and in patients with manifest overt coagulopathy, TIC. So basically, it's a contraindication in this population. And the CMDH statement tells us that yes, we can use starch still for the treatment of hypovolemia due to blood loss. Patients with trauma, yes, but there are no long-term trials. But again, severe coagulopathy is a contraindication, and at the first signs of coagulopathy, we have to stop starch. So actually, this is more or less contraindicated then in trauma patients. We have to use it at the lowest dose for the shortest period of time with continuous hemodynamic monitoring. Hemodynamic goals should be achieved. And my personal understanding is that even in the situation of managing a trauma patient, a severely traumatized patient, we should have the time and the facilities and the structures to do a good hemodynamic monitoring, not only a pressure-based monitoring. One study that really led to this change in the conclusions of the EMA is this one, the first trial, where we have seen that the lactate clearance, the perfusion of patients was better maintained by the use of colloid by tetrastarch compared to saline. Statistical considerations here, now looking into the main outcome parameter of the CHESS trial, the main trigger for all these EMA processes is, and this was very nicely highlighted by Professor Lobo, that all the rifle criteria were better actually in the colloid in the tetrastarch group compared to the saline group. But the number of renal replacement therapies was higher. 253 in the Hayes group required CRRT, and when you run a chi-square test, then you end up with a P of 0.044, statistically significant, overwhelming proof of harmful and of nephrotoxicity. But if 2 RRT indications would have changed, and this was, I remind you, at the discretion of the clinician to indicate CRRT, then you come to a p-value of 0.054. The message would have been completely changed if 2 out of about 7,000 patients would have been treated differently. Again, my trust and my confidence in our values here, in our evidence-based medicine understanding, is that in the 6S trial, it's the same situation. 87 patients required RRT in the Hayes group, 0.044. If only one patient, one doctor, would have indicated CRRT differently, then we would have had a p-value of 0.054. It's not a game, it's just a consideration of how we understand evidence-based medicine, and we should really carefully consider this. One big trial that really showed us that initial colloidal volume therapy saves lives in that way that 90-day mortality was lower, statistically significant lower, has been published recently and discussed in the morning session here. Also, the benefits of reduced, of more days, ventilator-free days, and more days without vasopressor use, and comparable CRRT requirements should confirm us that initial colloidal volume therapy is of benefit and life-saving potentially for our critically ill. Still, my topic is trauma patients and not critically ill and septic patients, but trauma patients may become critically ill patients later on and may be transferred to the intensive care unit later on. And when we look into this wonderful, beautiful, brilliant study of Christo, the subgroup of trauma patients was very small. 13 patients had in the colloid group here the risk of death of after 28 days. However, because of the broad confidence intervals, no statistically significant benefit whatsoever. I would like to thank you for your attention, and I would like to thank the organizers. I learned a lot, got many informations here on that meeting, and enjoyed it very much. Thank you.